Now we move on to the next presenter. We have Dr. Rabecca Kayumba. I request Dr. Rabecca to unmute and share her screen.
All right, so I'm Rabecca Kayumba from Zambia, a student with Texila doing my PhD. The topic of this study is influence of sanitation and hygiene practices on pregnant outcome. A case of postnatal women with preterm babies referred to the Women and Newborn Hospital. The number of women being referred to the neonatal intensive care unit at the Women and Newborn Hospital has significantly increased. Sanitation is the provision of adequate infrastructure and services in order to prevent diseases. The main pillars of sanitation include having access to clean water free from pathogens and chemicals for domestic use, access and use of toilets that are well designed to dispose of waste, proper sewerage management systems, proper garbage disposal, and access and use of sanitizing agents for proper cleaning to avoid ingesting pathogens. Hygiene, that is personal, environmental, and food, refers to conditions and practices that help to maintain health and prevent the spread of disease. Researchers, health personnel, and many people from different sectors agree that adequate clean water, sanitation, and hygiene, as well as bad attitude from community members, is a big challenge for many developing countries. Statement of the problem: despite significant advancements in medical care, preterm birth continues to pose significant health challenges for mothers and newborns in Zambia. Besides, there is limited literature with regards to the specific influence of sanitation and hygiene practices on pregnant outcomes in this context. Understanding this relationship is crucial for developing targeted interventions to improve maternal and infant health in Zambia. By means of this research, it is hoped that this gap would be filled. Rationale and need for the study: the prevalence, as already alluded to, of neonatal deaths in Zambia has continued. The current prevalence of women giving birth to preterm babies in the past 6 years also continues. So absence of water, sanitation, and hygiene, as well as other related factors, can contribute to adverse maternal health outcome. This study may help government and other stakeholders to bring in more interventions at prevention level rather than after occurrence of a preterm birth. Research objectives and their questions: to identify socio-economic factors related to sanitation and hygiene as causatives of preterm birth, to identify lifestyle factors related to sanitation and hygiene and associated with preterm birth, to examine nutrition intake embraced by the women with the preterm babies, and what follows are the questions in line with the objectives. Methodology: research design and mixed methods were used, and the estimated population was 3,840. Questionnaires and interview guides were used on 384 respondents. Simple random sampling was the most ideal sampling needed to select respondents referred to the Women and Newborn Hospital. The statistical package for social sciences, version 25, was used for coding of data. Data presentation: the data will be presented according to the research questions as follows. Number 1, socio-economic characteristics. Number 2, lifestyle of women with preterm birth. And the third one, food literacy. Socioeconomic characteristics. The study, as we can see, revealed that those education attainment, those who attend primary were 96, those who attend secondary were 160, those who attend tertiary were 68. Marital status, those married were 94, those divorced were 74, those who were never married 216. Places of residence, the rural 107, the shanty compounds 220, the urban 57. Water supply and sanitation, those who had were 133, those who did not have were 251. The ages, initially we thought would start from 18 years going upwards, but we found that age actually starting from 14. So the segment of 14 to 18 years were 44, 19 to 23 were 142, 24 to 28, 111, 29 to 33, 41, 34 to 38, 98, and above 39 years were 18. Occupation status, those in formal employment were 67, the business women were 134, the farmers 119, and those who did not fall in the above category were 64. Lifestyle of women with preterm birth, the antenatal attendance from 1 to 3 months, those who attended in this range were 59, 4 to 6 months were 121, 7 to 9 months were 204. Then those that checked up on infectious diseases were 124, those who did not were 260. Then those that had peer support were 139, those who did not have were 245. Then the home visits by health staff, those that strongly disagreed were 91, those that disagreed were 207, those that were neutral were 30, and those that agreed were 56. Prescription of medication, those who prescribed as well as the families, 204, hospital prescribed were 45, traditional were 135. Then those who took alcohol were 243, those who did not were 141, those who smoked were 304, those who did not were 80. Food literacy, those that were aware of the nutrition value of local indigenous foods were 41. Those who were very sure about it were 41. Those who were aware but not very sure, 115. Those who were completely not aware were 228. Then those who had belief in food taboos were 312. Those who did not were 72. And the common foods that were forbidden were red meat. Red meat was supported by 114, eggs 128, milk and dairy products 73, spices 39, vegetables and fruits 30. So from this, we see that the majority of women had up to basic junior secondary level, and few were illiterate. And then 17.7% had up to tertiary education level. Both the level of education and antenatal education were needed for the women in this study in order to reduce maternal complications related to ignorance. The age, we see that 14 to 18 years were captured. 19 to 23 also had 28.9%. So lack of sanitation coupled with teenage age contributed to unhygienic practices, worse with non-attendance of antenatal. The majority of respondents were those that had never married, meaning that they never experienced a stable family support in relation to maternal safety and care. And majority of the respondents were either small-scale farmers or involved in small-scale businesses which did not fully support their financial needs. And the 16.4% were unemployed and took up any kind of cleaning work without proper knowledge and practice of hygiene. So exposure to unsafe working environments, unfavorable socio-economic environments, and lack of nutritious foods all contributed to both mental and physical stress which affected the unborn child. Most of the women came from shanty compounds where solid waste blocks, drainages leading to flooding because of abnormal populations. And we observed the previous rainy season that women and children were swimming in dirty pools, which is making government efforts futile. So fragile and weak immune systems due to lack of proper nutrition diets fight off bacteria from the environment. Hence, most of the diarrhea or cases such as cholera emanating from shanty compounds. Women in areas with poor sanitation and hygiene are at risk of urinary tract infections even before they get pregnant. So majority of respondents in this study admitted not having good water supply and sanitation facilities. Defecating, bathing, and managing menstruation in open places can indirectly affect water meant for personal and food hygiene. The private places sought by some pregnant women are not safe because of being away from home. So literature has shown that poor sanitation and hygiene, occupation risks, lack of employment, poor residential areas, teen pregnancy, and low levels of education can truly have adverse outcomes on pregnancy. However, on education, other studies have shown that nutrition knowledge had more impact on food choices rather than the level of education. Under lifestyle, we see that 53.1% in this study did not seek medical attention as early as possible. They had their first antenatal visit between 7 months and the actual day of delivery. So failure to attend antenatal counseling puts the mother and the developing baby at greater risk of optimal development. So, and then majority of the respondents did not check for infectious diseases during pregnancy. And also the self-prescriptions of medicines, majority of these did, and some also sourced treatment from traditional sources. Beer drinking, majority of respondents confirmed drinking beer during pregnancy, a lifestyle meant to relieve themselves from stress. And majority of them smoked in form of sniffing, what is known as insunko, during pregnancy, meant to warm their bodies and tighten their private parts in order to please their partners. Sniffing was embraced because of its ability to increase libido and sexual pleasure. And it was, the respondents did not even mind any negative side effects as long as they pleased their partners. The sniffing was sought from unkept in unhygienic environments, including dirty wrappers, and shared without washing hands. So studies have found that early antenatal care, checkup on infectious diseases, self-medication, abstinence from beer and smoking can improve pregnancy outcomes. Food literacy, which is learning what to eat, how to access it, and ability to apply the knowledge for better health, according to Block et al. 2011. So with the high cost of staple food in Zambia, majority of respondents were not aware of the nutrition value of the traditional foods such as bambara nuts, pumpkin seeds, millet, sorghum, and cassava. And self-beer drinking and sniffing would be replaced with exploration of food products to replace mealie meal and the practice of cooking simple but nutritious meals. So the majority again believed in food taboos during pregnancy, which further put them at risk of biological stunting during pregnancy. The foods avoided from highest to lowest impacted on negatively on maternal health and also the developing child. Conclusions and recommendations. Sanitation and hygiene practices can contribute to preterm births in Zambia. Therefore, government to establish tested mobile antenatal services to improve pregnancy outcomes. Improved intergenerational relationships, communications, and policies essential to reducing child marriage and teen pregnancy. Deliberate health campaigns like those for child health week to be intensified in order to encourage pregnant women to attend antenatal clinics as soon as they discover they are pregnant. Traditional leaders also to work closely with health workers in disseminating nutrition, sanitation, and hygiene issues, and to address harmful food taboos. Traditional and civic leaders to also initiate participatory education to members of their communities in order to improve environmental and personal hygiene. More organizations to come in to help in settlements where there is no proper sanitation facilities. And penalties to people who contaminate the environment, also those that play in dirty water, smoking, water pollution, harmful garbage disposal, and so on, should be encouraged. Then the provision of nutritious snacks like that of Hygiene in Zambian schools, in some Zambian schools, can encourage attendance of these pregnant women, and also they can practice cooking of simple healthy meals at such health facilities. Thank you so much for giving me the chance to present despite the challenges that I've had today.
Thank you, Rebecca, for the wonderful presentation.